In this video, we are going to discuss about traumatic PPH and episiotomy. So first we need to understand what is PPH. So PPH means postpartum hemorrhage, means after the delivery of baby, blood is coming out. Okay, so this may be either due to trauma like any injury, or episiotomy means we actually use a scissor and will cut the end of the vagina actually to pass the baby head out. For example, take head of a baby is very big, right? So now we want to get that out, so we may cut the end of the vagina to wide it, or to open it up so that the head can come out. So that procedure is episiotomy, and during this procedure also a lot of blood is going to loss. So this is the heading which we need to understand. Now let us start first with the causes of traumatic PPH, that is because of trauma. Okay, so this is divided into four types, like perennial tear. Perineum, already in our videos in anatomy we discuss. Okay, so when that perineum tears, then the blood leaks out. When the cervix leaks, when the cervical tear, in that case also blood leaks out. In the case of hematoma, hematoma means a cancerous type of growth. Okay, and whenever there is ruptured of uterus, rupture of uterus. Okay, when uterus rupture, in this all cases, in these four cases you will have blood. Okay, this is a traumatic PPH. So first let us see about perennial tear. So what happens if the perineum tears? A tear which involves perineum. Okay, the classification of perennial tear is divided into first degree, second degree, third degree, fourth degree. What is this degrees? Let us see. The first degree is when the vaginal mucosa coming from inside to outside. For example, let me draw here. Okay, so this is a mucosa layer here. Inside you'll have muscle, here you'll have muscle layer. Okay, and outside you'll have the skin layer. Okay, so first degree means where the mucosa or skin of vagina are torn. So you can know this inside layer is the vagina's mucus. So this layer is done, that is the first degree. Next, coming to second degree means first degree plus vaginal muscles are torn here. So here the mucus is torn. Next, the muscle layer is also torn in second degree. Coming to third degree is where anal sphincter is involved. So you may get doubt, like now we are talking about vagina, how anal sphincter is coming here in middle, because this is the vagina which is present on the anterior aspect. On the posterior aspect, if you see, this one will be connected like this posteriorly with the anal aperture, right? So there will be anal sphincter. So tertiary degree is involved mainly with anal sphincter. So this tertiary degree is in turn divided into three types. The first one is A, second one is B, third one is C. A means here there is less than 50% of external anal sphincter has torn. You know that anal sphincters are divided into external anal sphincter and internal anal sphincter. For example, okay, so this is internal one, this is external one. So in the A type, especially external anal sphincter has got torn. Okay, next coming to the B type, here greater than 50% of external anal sphincter got torn. Okay, even B is talking about external anal sphincter. Coming to C, here both the external and internal anal sphincter is also torn. Okay, so that is which you need to see. Okay, so here less than 50% means only this much of anal sphincter got torn. Here greater than 50% of external anal sphincter got torn. In the C type, even internal anal sphincter is torn. So this is tertiary degree. Coming to fourth degree, where you need to mix first degree, second degree, third degree, and also add rectal mucosal tear. So what do you understand by fourth degree? Here actually the vaginal mucosa got turned, the vaginal muscle got turned, even the anal sphincter got turned, and along with that even the rectus mucosa tear. This is mucosa, right? The rectum mucosa also got tear. Okay, so now let us see what to do with this third and fourth degree tear. Third and fourth degree tear is a complete perennial tear, right? Because on the anterior side the vagina got tear, and the posterior side even the rectum and anal sphincters got tear. So how to prevent this perennial tears? So according to WHO there are some procedures, and according to WHO what it says we need to follow, and what it is not recommending, that also we need to follow. Not recommended, okay, that also we need to check out. So according to WHO says in the case of normal vaginal delivery for all females, we should not do episiotomy. That is, we should not always cut the lower part of vagina to for every normal delivery, because actually everyone what they thinks is by doing episiotomy only the blood loss will be low, but no, we should not do episiotomy routinely, okay. So instead of this we have one method to follow, which is said by WHO, that is modified Ridgen maneuver. Modified Ridgen maneuver. It is manually supporting the perineum with the right hand. For example, you can see this is my right hand, okay. So I need to support the perineum while delivering the head of the fetus, okay. First we need to deflex the head of the fetus with the left hand, and next we need to extend the head, okay. So advise a patient not to bear down while delivering the head. So these are the some of things which are recommended by WHO, and which is not recommended by WHO is WHO doesn't recommend episiotomy in all females who are undergoing vaginal delivery. The same thing we have discussed, okay. Again let me write it. Episiotomy is not recommended in every female, and RCOG recommends warm compress to be applied at the perineum. It says like some warm cloth should be applied near perineum, but this is not it is saying that this RCOG, according to RCOG, if you put some warm cloth near the perineum then there is low chances of tear, okay. But WHO is not recommending this RCOG method. Only it is saying first you need to deflex the head of the fetus, next you need to extend it and put the right hand for the support, and with the left hand you need to drag the head of the baby, okay. And advise a patient not to bear down while delivering the head. That is a modified Ridgen maneuver should be followed according to WHO. Now coming to the management of, okay, so now we understood everything. So now how we are going to do management for this perineal tear. So first time to repair the 3rd and 4th degree tear. First let us see how to repair the 3rd and 4th degree, because they are very dangerous, right? First we'll see this. So first you recognize if this tertiary and 4th degree tears, means tertiary means anal sphincter got tear, 4th degree means uh, almost everything, almost complete perineum term. That's why we are saying in 3 degree or 4 degree we are saying complete perineum got torn. So if this is recognized within 24 hours after delivery, then we need to do immediate repair, because you got to know about this just within 24 hours after delivery, right? And if it is recognized greater than 24 hours, after greater than 24 hours of delivery, then we need to wait for 2 weeks and repair after infection. And actually why we are waiting for 2 weeks is because there may be some infection, inflammation which is going on during especially after delivery, right? So after all those infection and inflammation subsides, next we can go for this repair process, okay. Always remember that if there is any tertiary or 4th degree turn, then first we need tear, then first if it is within 24 hours, immediately you can do the repair. But if it is greater than 24 hours, please wait for it. Wait for till 2 weeks, because there's chances of infection and inflammation. After those complete, then we can go for this. Now let us see the technique. So you have understood everything. Now what is the technique of repair? So for 1st and 2nd degree tear, it is done in the labor room then and there itself, okay, under local anesthesia. Only you will give local anesthesia to that area, okay. And the steps which you do is, first one is you will suture the vaginal mucosa coming from inside to outside. First you will suture the mucosa, okay. You will put a continuous suture, especially using what type of suture, very important. For the mucosa you are going to use Rectal or polyglactin suture, okay. And next you will do the suture of muscle coming from inward to outward, here mucosa, next muscle, next outer skin, right? So second is suture for muscles, vaginal muscles. For this you'll use interrupted sutures. And next, coming to third suture, that is for the vaginal skin. And here you are going to use mattress suture. So you need to remember the names. For the vaginal mucosa, you are going to use Rectal or polyglactin suture. For the vaginal muscles, you are going to use interrupted suture. For vaginal skin, you are going to use mattress sutures. So now coming to third and fourth degree tear. For third and fourth degree tear, it is done in the OT. That is, you will use a general anesthesia here. So remember, in first and second degree, there's a small kind of minor repair, so you can do in the labor room itself by giving localized anesthesia. But here you're giving total body general anesthesia, and it is done in OT. So what the steps here you're going to do? First thing, you're going to repair the rectal mucosa. Remember, as it is second, third and fourth degree, here rectal mucosa is always involved. So first, rectal mucosa will get repaired. Second, internal anal sphincter, where you will do end-to-end anastomosis here. Okay, and the third one is external anal sphincter. So here also you're coming from inside to outside. Actually here this tertiary and fourth degree repair is mainly involving the rectal side. First the rectal mucosa, next the internal anal sphincter, next the external anal sphincter. So now coming to like what is the most common method which we use here in the 3 and 4 degrees is, the most common method is end-to-end anastomosis, and the best one is overlapping technique. Now fourth one, after this third step we'll go fourth step, that is repair the first and second degree tear. So actually what we mean is, in this third and fourth degree tear, you know, there is all tears which are present. It's a complete perennial tear. So after third and fourth degree, next we'll go for 1 and second degree repair. After that, you know, in the first you'll do vaginal mucosa, in the second suture you'll do the muscle, in the third suture you'll do the skin, vaginal skin. So this process is same here also. Okay, so what are the important points after the repair? This is very important. So important points after the repair is, pregnancy should be avoided for 1 year ideally, but for at least 6 months after second and fourth degree repair. So remember, after the third and fourth degree repair, at least the pregnancy should be avoided for the next 6 months, or you can say 1 year, because again the baby should come from the vaginal delivery, then it will be very painful, and you know, it will have problem, because just now we have put the sutures there. So in future these females can have vaginal delivery. And ACOG recommends a single shot of antibiotic at the time of repair. So this is important. ACOG recommends single shot antibiotics, because while doing this suturing system some kind of infection may pass. So to prevent that, it's better to give single shot antibiotic at time of repair. Now let us discuss in detail of cervical tear. So cervical tear. So for the cervical tear, the most common site is 3 o'clock position. 3 o'clock position greater than 9 o'clock position. Okay, this is the most common site for cervical tear. And coming to the management, repair the tear, that's it. Okay, so now let us start with episiotomy. Very easy and interesting topic, episiotomy. So episiotomy, the definition, it is actually a surgically planned incision which is given on the posterior wall of vagina. So surgical procedure in posterior wall of vagina to facilitate delivery of fetal head. So mainly it is to facilitate the delivery of fetal head. We will do some incision on the posterior wall of vagina. So the episiotomy scissors is bent. Okay, the scissors is bent and with blunt edges. So why it is bent and blunt edges? Because if it is not bent, then this scissor may directly go and pierce into the fetal head. So that's why it is bent somewhat, and it is blunt, that's why, because it will not give any harm to the fetal head. So now coming to this episiotomy, we will do two types of incisions. Let us see that. For example, so this incision which you give exactly at the center of the posterior vaginal wall, this incision is called as median episiotomy. Okay, and this incision is somewhat lateral, right? So this is called as mediolateral episiotomy. So these are the different types of episiotomy. About this median and mediolateral episiotomy, let us continue it in part 2.